start by thanking, a little bit less loud, UC Davis Health Systems, California State University, Sacramento, of course, the SED, for inviting us to present here today. We have a lot to really cover in 1 hour period of time. Really, we're going to talk about the who, the how, the what, and the why of educational assessment and planning. And it's a tall order for 1 hour, but we're hoping to be able to cover both process and practice. For those of you who are educators, and we do have many here attending the conference, we really want you to walk away with some ideas about gold standards and strategies and practice and tools that will help you to most effectively do your job assessing the needs of the learners on the autism spectrum that you work with. For parents and for the educational practitioners who are with us today, and I have to point out, this is a really unique opportunity for so diverse a group to be able to come together. We have doctors, physicians, pediatricians, nurses, folks from the regional center, service coordinators and clinical folks from regional centers around the state. We have educators, we have parents, we have parent advocacy groups, all here together in one place, really hearing the same information. So we hope that really we establish some shared understanding of what educational assessment is and what it isn't, and really how it does overlap in many ways with the assessments that are conducted by medical practitioners and by the regional center to really help to establish that shared understanding and clarify what it is we do in educational assessment. Disclosures, we have no disclosures to make in terms of conflict of interest. And the content, we do want to point out that the content of this presentation was guided by 3 primary resources. First off, we have in the state of California several sets of guidelines that have been developed through our Department of Developmental Services and the Autism Initiative. In 2003, they published guidelines for best practice in screening, diagnosis, and assessment. And we've drawn a lot of the content and a lot of the information for this presentation from those guidelines. If you're not familiar with them, they are an invaluable resource. They are free through the Department of Developmental Services website, and they do provide what I believe is a really, really well thought out description of these 3 processes that we do in screening, diagnosis, and evaluation for treatment planning. We also drew on the publication in 2001 from the National Research Council, Educating Children, and all of the evidence-based practices and best practices presented in that publication, as well as our years of experience working in education and as part of educational assessment teams. So I want to start by just establishing a shared set of understandings and terminology. And this is drawn directly from the DDS guidelines. First off, a definition of screening, which actually will be covered in much more depth by my colleagues, Dr. Robin Hansen and Gina Granieri, in the next session, where they'll be talking about early developmental screening and really clarifying the best practices and the evidence-based practices for screening. But these next 2, diagnostic evaluations and assessment or evaluation, this is where a lot of confusion, I think, really starts in terms of what the medical field and what the regional center does and looks at versus what educators do in our evaluations of students, specifically looking at students in terms of whether or not they qualify and are in need of special education services. So diagnostic evaluations and educational assessment, I think, is a really good place for us to start in looking at some of the similarities and differences. We're going to spend the bulk of the presentation really talking about assessment for educational intervention planning. But these 2 processes are similar. First off, diagnosis. This is a medical term. This is something conducted by medical professionals and utilized by our regional center system in the state to determine whether or not a child has a specific medical condition, which is outlined in the Diagnostic and Statistical Manual. Those of you who are familiar with the DSM-4 know that the criteria used to make that medical diagnosis is criterion-based. You have to have a certain number of the characteristic symptoms in order to have that label or be given that diagnosis of an autism spectrum disorder. Diagnosis is should be made by qualified medical practitioners who are licensed and who have expertise and experience in this disability or in any disability for which they're rendering the diagnosis. We do not diagnose in education. In fact, nowhere in Ed Code, nowhere in IDEA does it say educators diagnose. We look at the needs of students and how a disability or how a suspected disability might be impacting their ability to access the curriculum and make progress in the curriculum within an educational context. The term educational diagnosis is kind of a made-up term to describe one of the things that we do in educational assessment, and that's to determine eligibility. Eligibility is determined based on the assessed needs of the learner. And in Education Code, we have 13 qualifying disabilities that describe more the behavior and the impacts on learning that a certain disability might have on a learner. But nowhere in the Ed Code, nowhere in any of the documents that we use does it say that we diagnose, particularly autism. Autism is, however, described in the Ed Code as one of the 13 qualifying disabilities. In the California Code of Regulations, this is the description of autism or students who display or demonstrate autistic-like behaviors. You can see in looking at this and the following slides that it's very similar to the descriptions given in the Diagnostic and Statistical Manual. All three of the core areas of social, communication, and restricted and repetitive patterns of behavior are all indicated in the Education Code. So it discusses here that the pupil must exhibit a combination of the following to include, but not necessarily limited to, an inability to use oral communication for appropriate communication, a history of extreme withdrawal or relating to people inappropriately, and continued impairment in those social interactions from early childhood or infancy, from infancy through early childhood. An obsession to maintain sameness, extreme preoccupation with objects or inappropriate use of objects or both, extreme resistance to controls, and displaying of peculiar motoric mannerisms, motility patterns, and self-stimulating behavior. All three of the core areas of impairment are indicated in this description. But as educators and as assessment teams, we're also looking at other factors. A disability or a diagnosis alone is never enough to guide treatment planning. We have to look at how these symptoms are impacting the learner within the educational context. So I think it's really important that we clarify a couple of things. First off, do you need a clinical or a medical diagnosis of an autism spectrum disorder to receive special education services? And the answer to this is absolutely no. We have an independent process for determining special education eligibility. However, if a child comes to an educational setting, or if in the process of their education, the family seeks out a diagnosis, or a pediatrician identifies that a child may have an autism spectrum disorder, and they do get a medical diagnosis, this is useful information for the assessment team, for the educational assessment team, particularly if a comprehensive diagnostic evaluation, utilizing those guidelines of what should be included in a diagnostic evaluation, are brought to the IEP team. Because a thorough diagnostic evaluation done by appropriately trained and licensed medical practitioners can really give us a lot of information and a place to start looking at how the disability or how this child's needs can be met in an educational environment. Does a clinical diagnosis automatically mean that a child should and will receive special education? The answer to this is also no. Many children who have a medical diagnosis on the autism spectrum, a pervasive developmental disorder, Asperger's syndrome, may be benefiting from their educational program and making progress in the curriculum, even without special education supports and services. Some children may have this identified disability, but be able to make progress with a 504 plan, with some accommodations, with some allowances for different forms of input and output, but still with the expectation that they will progress in the curriculum at the same rate as their typically developing peers. It's only when the child is not demonstrating educational progress, they're not progressing in the curriculum, that the disability itself then and the needs of the child within the educational setting have to be looked at more closely. So we're going to spend the remaining amount of our time today with you talking about then what is involved in a comprehensive assessment, educational assessment for treatment planning. And we're going to talk specifically about the eligibility and about the practices that can be put in place to really yield the most effective information for a team to go about developing an appropriate educational program for a child who has an autism spectrum disorder.
Thank you, Patty. So as Patty said, educators don't diagnose. We're responsible for determining whether a child has a disability and how that disability impacts how they access education in a very broad sense, not just academically, but how do they access the classroom, their peers, their teacher, instruction, and the curriculum. What I want to start off with is what is different about assessing children with autism versus the other categories. And when I first started in the field, autism was considered a low incidence disability. And as we know, that's no longer the case. In fact, really just in the past decade in special education, according to the national statistics, it's doubled. The number of kids that we serve in special education with autism has more than doubled. So our ability to assess and really understand educational needs, respond to those educational needs, the demand for us to be able to do that has really multiplied. And we're all really feeling this. So what is different about ASD versus other educational categories? As Robin so eloquently explained earlier, ASD is a very complex neurodevelopmental disorder. And it's made up of very heterogeneous groups. There are different types of autism we're learning. It looks different. One child who comes through our door to our assessment team, and I have the privilege of working with a great group in Folsom Cordova, our early childhood assessment team, looks quite different than another child. And so because ASD, the nature of ASD, affects multiple developmental domains, it can look so different, especially in the young child. It requires us to have a very comprehensive multidisciplinary assessment. And I think more than perhaps in other disability codes in education, it's really requiring educators to be experts. When parents come through the door and for our team to assess their child, they're really hoping and expecting that we have developed expertise in autism. And that's something that over the past 20 years we have really had to come up to speed, given the fact that now autism is really far more common than it once was. And because it requires a multidisciplinary team, it requires more communication, more collaboration, more time. For me, personally, as a school psychologist, it takes three times more in terms of assessing a child on the spectrum than any other child. Typically, I see children 3 times. I have 3 sessions. Usually 6 to 7 hours is direct assessment, and that's just the assessment. That's not the report. That's not the IEP team. That's not developing their education plan. It requires a lot of time. I think the other difference is in education, all the tools that we've been trained in, those standardized assessment tools, some of them are helpful, but a lot of them just throw out the window. I mean, they're not helpful to us for many of these kids, especially the young child, 3 to 5-year-old, but many of those standardized tests require some degree of adaptation, or we may not even be able to give the test to the child. We may need to take more frequent breaks, make accommodations, use systematic reinforcement. And for that reason, we really need to be able to rely on more unstandardized, what we would consider informal, but for me it's probably 50% of my assessments rely on natural observations and structured observations with my team. And because there's such variability, especially in early childhood development, and it's such a heterogeneous group, you really need to know your childhood development. You really need to know across the domains what is typical, what is atypical, and what is that pattern of behaviors you're seeing with the child indicating to you. And one of the major differences makes it more complex for us is there are frequently comorbid conditions, coexisting conditions, and rule-outs, things like differentiating between what is maybe sensory integration, that's a big thing that's coming up and is more prominent, communication disorder, oftentimes there are other issues, cognitive impairment, anxiety and depression perhaps to be looking at, especially in the older child, and cognitive delay. So what does gold standard assessment for autism, and this is from the National Research Council, really there are 7 key elements to gold standard, what we call gold standard assessment. Number 1, it is an interdisciplinary process. It really is ineffective to go about it with different disciplines, seeing their child in their individual offices, especially I do lots of early childhood assessment. That's far less useful an approach, and is probably kind of the standard typical approach. It needs to be interdisciplinary, and we'll talk about that some more. It involves structured and naturalistic observation methods, use of measures with solid validity, and I'm going to go over a few, especially those that are particularly helpful in education. Are conducted by educational specialists knowledgeable in ASD, folks who have really gone out to get additional training, additional experience in understanding autism, what autism is. And it addresses all areas of suspected disability. And as we know, children with autism, it affects almost every developmental domain for them. Almost every kind of functional domain is affected by autism. And it also identifies the unique needs of that child to direct intervention, goals, and services, and is inclusive of parents from day 1. So involving the parent. For me, this is establishing a foundational relationship that hopefully is going to help lead to the future planning, the future educational planning for that child. And what's the bottom line in terms of a relationship that's really going to work? And the bottom line is that there's trust. There's trust established. The parent feels that they can put their child in our hands as educators, and that we're going to take care of that child, that we're going to know what to do and how to assess that child. And it involves that mutual respect, acknowledging that both educators and parents bring to the table unique perspectives about the child, and value each other's perspectives and are open to one another's perspectives. And parents, for some parents, they're really in a crisis. This has really thrown them into a crisis mode. And so what do a lot of us, think about what a lot of us do when we're in a crisis. Sometimes it's that fight or flight or fight, right, to get what you need, to make sure things are going to happen. And so I think it's really important for educators especially to recognize that when parents come to the table, they are really themselves faced with quite a challenge and maybe in a crisis. And so we ought not take personally maybe that they might be coming to the table sort of demanding, expecting that we're going to have some things happen for their child. I think that that's perfectly understandable, and we need to just understand where the parent is coming from and start developing that positive relationship. So from the educator perspective, from the educational teaching perspective, sorry, I reversed it. From the parent perspective, I know my child, and that's for sure. The parent lives with 24/7, but she knows how to teach. I know how to teach. He knows his child. Hopefully we can come to the table with that mutual respect and collaboration. So where do we start with how to implement gold standards? And that is really forming an autism assessment intervention team. And that can look differently. I've been spending time with different districts training them on how to set up their teams. The way that I have worked is with an early childhood assessment team. So we do all children 3 to 5. And it's interesting because what I've experienced is that about a third of the kids that we're seeing in early childhood are ending up kids who are on the spectrum. That's about a third of my caseload. So quite a few. But in some districts, it may be that they're really going to specialize and have an autism assessment team. We sort of have both in Folsom Cordova. And in previous places where I've worked, we've had specialists who come into our early childhood team and really specifically look at autism. And that team really needs to involve a behavior specialist or analyst. They bring to the table a unique set of skills and ability, knowledgeable in ABA, speech therapist, occupational therapist, classroom teacher, special education teacher, nurse, and school psychologist. And we really ought to have on their parent. And there may be other specialists at times that you need to include, but you want to have at your availability these kinds of folks on your assessment team. And I personally love working on a team. More than one head is better, for sure. More than just my perspective is going to be better for the child and the family. And we're going to collaborate in a very interdisciplinary way and design assessment tasks, design how we assess the child and probe for behaviors and look at what's really going on with that child, but by designing activities where all of us benefit. And by doing that, the team really generates a far more meaningful report, I have found, for parents, because it's integrating that information, it's putting it all together very nicely for that parent in a meaningful way, and then it's providing clear direction. I mean, ultimately what we want is clear direction for what to do for the child. The other benefit is we can sort of triangulate data. We can take data from different perspectives and go, oh, this is all really coming together and indicating something really clear to us, or no, it's not. This is not clear to us, and maybe we need to look at something else. I have a great recent example. I worked just last week with a speech therapist in OT with a 5-year-old little boy with autism, trying to figure out what to do for him in kindergarten. And he doesn't know me, I don't know him, but we started off pretty good, and I had some great reinforcers, his favorite primary reinforcers, some jelly beans and his favorite cookies, and of course these are all approved, and that's really important. Make sure your primary reinforcers have been approved ahead of time. And he was even working with me on some standardized assessment and doing some pattern construction for me, and I was very excited about this. He gets to choose what he was working for, which was a green jelly bean. And he gets his green jelly bean, and I'm thinking, great, now we're moving on to the next thing. What happens? Tears, screaming, crying, and the day before I'd observed a 2-hour tantrum that led to some hair pulling and biting, and I was going to try to avoid that as much as possible. And I'm thinking, what happened? I have no idea what just happened. And the speech therapist who had been observing, who has some knowledge of the child, sort of came up to me and she said, I think it was the wrong green jelly bean. That wasn't the right green jelly bean, it was the wrong green jelly bean. And you know how that can be when you're eating jelly beans and you get the wrong green one. You were expecting watermelon and you got, sour, apple, So I went, oh my gosh, okay, well, let's just present him with this, and he's just, so upset and so unhappy. And that was the yucky green jelly bean. Is this the green jelly bean? Is this what you wanted? And he was like, yes, that is the green jelly bean. Gave him the green jelly bean. We were back on track. He was all regulated again. We did let him go play with the OT for a while. She has all the fun stuff anyway. And then he came back to the table, and sure enough, I was able to complete the whole DOS. I was very excited, the DOS too. So I'm sure we all feel this way from time to time. This would be, people going in different directions. I think a lot of parents can relate to this. This is how a lot of times I think they feel. I've got one agency taking me here. I'm trying to figure out what my medical provider can do for me. I'm dealing with, what the heck is education and an IEP and all of that. And I think, sometimes our kids feel that way, and sometimes we feel that way. Where are we going? What are we doing? And so by having a team that really is making it their mission to know autism, to know how to assess autism, hopefully we can prevent this from happening. So the assessment. And these are all the areas we know are affected by those core deficits. Those 3 core deficits have a huge expression. We need to do a behavioral assessment. There are likely interfering behaviors or specific autistic-like behaviors we need to understand. Sensory and motor issues are a possibility to consider. Adaptive behaviors, we need to know what their daily living skills are like. Communication, pre-academic and academic skills. Socialization, cognitive functioning, executive functioning, a kind of a subcomponent of cognition, but kind of on its own now, we're really needing to look at that, and health and developmental. So what do good assessments include? And like I mentioned earlier, for me, really, probably the meatiest part of our assessment includes the first 2 things here, natural observations, and ideally in multiple settings and by multiple observers. What the speech therapist or OT may observe in the child care setting may yield different information than what I might observe when I go do a home visit. But I have found that, and it's a unique opportunity. Many practitioners in the medical community don't have that luxury of going to the home or going to the child's child care or preschool. We can do that. We can see the child on the playground. We can see the child in their classroom interacting with their teacher. We can see the child in their peer group. That is a huge advantage, I think, to educators and yields a lot of important information. Structured observations are designed specifically to elicit those behaviors that we know are linked to autism, the social reciprocity deficits, et cetera, and I'll talk about that more specifically. We do want to use standardized assessment measures, though. They are objective. They do tell us where is that child relative to his or her age mates, and that is important, but has limitations. And we want to do a parent interview, extensive parent interview, and use rating scales that ideally we can gain from multiple raters, so you have multiple looks at the child. So what are the specific behaviors to elicit during a structured observation? And this is where your team can come together and develop your play, your bags of goodies and toys, and have different kinds of activities that are going to elicit behaviors. We want to elicit reciprocal turn-taking. Does the child have a sense of, I do, you do, my turn, your turn? What is their natural inclination for pretend play? If we give them some, for boys it's going to be different than girls, but you're going to give them a set of toys that ideally they're going to feed the baby, or they're going to make the fire truck go and make noises and put out a fire. What is their social reciprocity? Do they have the sense of, most of us are pretty fun in our evaluation? Are they engaged by us? Are they interested in what we're doing? Are they looking at our facial expressions and going, oh, that must be something very cool to do. Look at how, excited she is about, playing with this baby doll. Should I be excited too? Or is that something they're not picking up on? Are they actually actively avoiding? A lot of the kids will actually actively avoid that attempt to interact. They're under the table, screaming and crying, and sometimes saying, go away, get out of my space, I don't want you messing with me. What is their ability to imitate novel acts? Gross motor, fine motor, verbal. If I jump up and down and wiggle, and I say, you do that, you jump up and down and wiggle, are they able to imitate something like that? What is their ability to be directed, to actually be engaged by the examiners? Their use of toys and objects, is it more sensory-based? Are they more using them for kind of repetitively versus exploring the toy, manipulating the toy, and using it in a more purposeful manner? What is their functional use of communication? How is it that they express their needs and wants? And so we set up situations for them to, in fact, have to communicate to mom or to other people or dad or to other people in the room. And what is their use of nonverbal behaviors? So if I go, and I look at mommy and, mommy's got a fun toy, are they reading my facial expression? Are they getting that joint attention? She's pointing to mommy. I'm going to look at mommy because she sees something really interesting. Are they responding to nonverbal behaviors and using nonverbal behaviors? Standardized assessments, uses and limitations. We know it provides objective data, but like I said earlier, you may absolutely you're going to toss it out the window. Not one standardized test is going to work for this kid except from a parent interview. And so we need to be able to note in our reports the limitations of those tests. So I may only be able to give a portion of a cognitive measure, not the whole thing. And I really need to indicate, this may be an indicator of their current functioning, but in many, many cases, I can't really tell the parent that I know what your child's cognitive ability is, but I can tell them this is what your child is showing us right now, their functioning is. Reliability can be an issue, especially with kids on the spectrum. Mom might say, he did that yesterday. I know he can do that. He did it, but today he's not doing it. And that's often because in novel situations, a new situation, different person, different objects, different items, different environment, it's a totally different experience for that child, and they may not be able to perform it then. Cognitive assessment. It's important to use good, broad cognitive measures for kids on the spectrum, but to also consider using nonverbal tests. Using nonverbal scales, using alternative assessment measures, and to use processing tests to look at their memory processing, verbal visual memory processing. They may have a unique profile in terms of their working memory or attentional processing. For older kids, I like using the CAS, the Cognitive Assessment System, because it does look at a lot of different kinds of processing, cognitive processing. For the younger child, I really like the DOS-2 because it has lots of nice manipulatives. But you can also use the NEPSI because it goes down to such young ages, and you can look at attentional processing and other types of cognitive functioning. It's important to know, what did the child need to learn a task? How many trials did they need? Did they need me to show them 3 or 4 times, and then they got what it was I wanted them to do? That's important information for the team. Now I want to talk about what are specific tools that look at autism. Now, even though we don't use the DSM-4 to diagnose, we do need to understand the DSM-4 pretty fluently in order to, number one, be able to administer many of these tests, because most of them are based on that DSM-4 criteria. So as a psychologist, I am pretty fluent in what the DSM-4 says. And the ADIR, as an example, which has solid psychometric support, Robin mentioned that earlier, is a very lengthy interview, but a very good tool for educators, because it's that opportunity to really get that extensive information from the parent, and because it has really the best psychometric support. The social communication questionnaire is actually sort of a relative to the ADIR. It's intended to be more of a screener, but it has high predictability for identifying children with autism. But it is designed really for children 4 and older. You can use it for younger children, but you sort of have to qualify that. One of the things I think educators are very familiar with is the CARS. Now, I think you'll be happy to know that it has sufficient support. And the CARS has some advantages in that you can combine both observation and interview. And you can get more than one observer, more than one rater, which is really helpful in understanding what autism may be whether that child has autism. You may not be familiar with the social responsiveness scale. I've started using that more and more, especially for the older child. That has very good psychometric support and gives you specific information about social cognition, social motivation, autistic-like behaviors, and is and it has a teacher rating and a parent rating, and I really like that, because as educators, I want to know both what's happening from a parent point of view, and I want to know what's happening from a teacher point of view. The other ones that I just want to point out quickly so that I can move on, the ADOS is used very extensively in our area, and that's observation, and really requires lots and lots of experience in administering. The Child Behavior Checklist is a well-known measure for children ages 1.5 to 5. It has a PDD scale, and that has pretty good support in terms of I view that sort of more as a screener. Are we possibly seeing a child on the spectrum? And if the PDD scale really is coming up high, I'm going to investigate further. I've already kind of mentioned the limitations. Some of these are really designed for ages 4 and up, unfortunately, and you really kind of have to qualify based on that. The ADIR is very time-consuming. It takes 2 hours, sometimes more, but you have to allot at least 2 hours. Most scales don't integrate multiple raters, and so what I like to do is integrate the data from multiple sources, from our natural observations, our structured observations, and that parent interview, so that we have lots of nice data that we can look at in terms of figuring out or differentiating, is this a child with autism, is this a child with a communication disorder, an attention deficit, or something else. And lastly, I just want to mention that the most important instrument is the evaluator. And most of the studies they've done on the use of these various measures, it really does boil down to your fluency and your competence and confidence in really knowing what autism looks like.
Thank you. So Chris has, boy, I'm loud, sorry. Chris has gone over some of the gold standard methods and some of the tools and instruments. But I think it's really important that we look at specifically going back to the education code and what it says about autism. Your natural observations of the child within a variety of contexts and looking for specific behaviors that are described in ed code, what you're seeing or perhaps what you're not seeing. Are you seeing it the same way as some of your other team members are? So we've provided for you in your course material several forms that we've found to be really useful in doing your naturalistic observations and in doing your structured observations, both for looking at the education code description of the autistic-like behaviors, as well as some for functional communication and some for looking at some of the social differences that might be observed in these learners that may impact their ability to access the curriculum and function within the educational context. What I did notice on this particular form, the education form, when we sent it electronically, it didn't translate real nicely. So there are some typos on there. And also one thing was left out, and that's looking at the severity scales. The Diagnostic Center, Drew Sarin, put together a really nice way of kind of quantifying what is it when people view it as severe. And so the 54321 is a way of really quantifying and establishing that inter-observer reliability for each of these behaviors, and that was accidentally left out of the handbook. So come and see me if I get your email or if you send me an email. I can make sure that you get actually corrected versions of these forms if you think it'll be a useful tool. What it should say is educational descriptions of autistic-like. That's what that form should say. So that breaks down that ed code description that I read to you earlier and provides a way for the team to be able to cite examples and cite observations of the behaviors described as autistic-like. Chris mentioned executive functioning and an area that really needs to be looked at closely, particularly with those students who are on the higher functioning end of the spectrum, those students with Asperger's syndrome. This is an area that really is and can significantly impact their educational performance. We're looking at their ability to focus and to shift attention, their ability to plan and organize. So it might not be an issue of them being able to give an appropriate form of output, but it may be that they can't organize all of the information that's incoming or organize all of the information to be able to demonstrate that they understand something. The other thing is that with the executive functioning, it has significant functional impacts. So a child might have a difficult time gathering their materials to be ready for the instruction. Or when it comes to completing complex assignments, not being able to organize the steps or the process. for completing the report or the project. So we really have to look closely at executive functioning and how that might be impacting students' ability to access the curriculum and meet the standards. There are some standardized assessments for executive functioning listed here. There are also some really wonderful rating scales. The brief is a really useful tool for looking at executive functioning. It provides really a way of viewing how the functional impacts of the possible impairment. Naturalistic observations, again, really, really important. And then, of course, the parent and teacher interview. And some of the things that seem sort of trivial but can really give you big clues in terms of how this child is doing are things like, how frequently do they lose their lunchbox? How many lunchboxes have you had to buy this year, Mom? How many times do you have to go to the lost and found per week? And that can be significantly different for children who have these impairments in executive functioning and can translate to problems with being able to keep up with the curricular demands and the demands of process that increase as the grades advance.
I want to just add before talking about adaptive behavior really quickly. For me, observing especially the older child where in the classroom they're expected to keep up with the pace of instruction, shift from one thing to the next, get ready, finish one thing up, get ready for the next thing. What is their ability to shift? Is that child still, completely, lost or involved in the assignment 2 assignments ago and is nowhere even near to catching up with where they're supposed to be in terms of instruction and shifting? Sometimes it's even from their ability to shift from one item to the next item, to shift from that one page to the next page. And so that ability to shift attention is a huge piece, and your natural observation in the classroom is going to be helpful, really helpful to you. Adaptive behavior, most of you are really fluent in giving adaptive behavior measures. I personally really still like the good old Vineland. We need to have a sense of what is the impact on their daily living, their self-help skills, their ability to access their community, for the parent to be able to take them to the grocery store, to go out to dinner. Many parents will say, I cannot take my child. We cannot go out to dinner. Maybe we last 5 minutes. That's really important to know in terms of what are the specific skills that we can help develop in that child so that they can be more functional, and parents can take them to birthday parties, take them to the park, things that we kind of take for granted but are so important to parents. Real quickly, academic assessment. I think this is something educators are really fluent in, but we need to consider using other measures other than the ones that we typically give, like the Wyatt, the KTA, the Woodcock-Johnson, et cetera. We also need to be able to look at work samples. Qualitatively, where is that child relative to his or her classmates? I always look at work samples, the quality of it. Are they writing as much? Is the content there? Are they really getting the ideas? And for me, a marker is if they're only producing 50% of the work in that classroom, or they're only able to function in about 50% of the curriculum, that's a huge impairment in terms of their ability to perform in the classroom. Now, your standardized tests, this is one of the things I know frustrates parents to no end. Their standardized assessment may, in fact, show that they're functioning in the average range on just those reading skills or math skills, especially if it's a rote skill, that they've mastered. And yet their ability to really keep up with that curriculum, and if they're only doing 50%, they're not keeping up with that curriculum and they're going to be falling behind. That's a huge indicator. So we need to look at work samples and how they're keeping up with the pace of instruction. And what is their level of frustration tolerance? Are they able to start that paragraph and finish it? Or does it take 20 minutes to get them started? And maybe eventually they do produce a paragraph that has the elements you wanted, but it took a lot of prompting, it took a lot of visual supports to get there.
Sensory motor is another really important piece that we need to look at and try to understand. And looking at sensory processing, a child who may have an overreaction to certain things in the environment most likely is going to be exhibiting behavior to kind of try to protect their sensory nervous system and eliminate some of the input that might be coming in. And that in and of itself may prevent them from accessing the instruction. Looking at the motor and how the sensory and motor work together. I know that in my experience working with the older students and the higher functioning students that they may be able to produce in writing. They can write. But the problem oftentimes comes in when the workload, the expectation of output begins to increase. And maybe it's a child who grips the pencil too firmly or pushes too hard on the paper. And once they get up into 5th, 6th, 7th grade, the amount of production they're expected to do in writing starts to become an issue. It starts to become a factor for them. And we start to see either behavior in order to escape and avoid certain types of activities, or we start to see the production go down. And so this is an area that does need to be looked at. The occupational therapists are really the most qualified to assess in this area. They may need to be called in if this appears to be an issue, not necessarily part of the initial assessment, but if we're looking at and we're finding clues and seeing that this is an area of need, they can certainly conduct more specialized assessments and really provide some good strategies for educational planning. Communication, obviously one of the core areas that is impaired in autism spectrum disorder, so needs to be looked at closely. There's the communication aspect and the language aspect. And so a couple of them that I really just want to kind of highlight and focus on is looking at functional communication, the ability to get their needs and wants met in an effective way, to ask for things like help and assistance. To be able to communicate when they are feeling overwhelmed and need clarification on what the expectations are. The child may have wonderful vocabulary, they may hear everything you're saying, but when too much information is coming in, they're not able to hold it in their working memory, and so therefore they end up not being able to do the task or perform the expectations. So we need to be looking at functional communication as well as then pragmatic and social, and looking at that more closely. So a couple of things related to functional communication, and again, we've provided for you in your course materials a structured observation form that can be used that really highlights these main areas. We need to be looking at how are they currently performing when asked to do certain classroom-based activities, school-based activities. What level of prompting are they needing? Are they doing it appropriately? Are they relying on some other compensatory strategies, like if they miss the instruction, are they able to look and cue off of their peers? How are they doing in terms of accessing the items needed throughout the day? How are they doing when they're asked to wait for certain things? And that instruction to wait may be explicit or implicit. There are many, many times throughout the course of the day that we ask students to wait for the next instruction, wait for the transition, and this tends to be an area that these kids really struggle with. We also want to look at requesting and their ability to self-advocate, asking for the items they need for help to get out of situations that they find overwhelming or frustrating, and their ability to accept and reject items appropriately. Just because someone has vocabulary does not mean that they can actually use that vocabulary to communicate these basic needs and wants. And in my experience, when there's deficits here, you're going to see problematic behavior as their main means of communicating these basic things. So there are formal and standardized assessments that are available on functional communication. These can give you and yield some very useful information. However, that observation is really going to be your key to understanding how that child is performing. Pragmatic language, just quickly, a few assessments that are available for pragmatic language. I do want to caution you, though, that the mere nature of the way that we give these assessments, oftentimes the child can perform well in a highly structured, predictable, where the material is given in a concrete, static sort of format, where they're given time to process and think about what the appropriate answer is. So you're going to have scores that look like the child really understands some of the social subtleties. But you look at that same child in a naturalistic setting where things are dynamic and where the social judgments have to be made very quickly and they have to pick up on multiple things at one time, and you're going to see something very different. So using a combination of some of those standardized assessments, the developmental, and then also your observations are really going to give you the most valuable information about the child. How does social impact educational performance? It's really important that we realize that school by nature is a social environment, and that working in groups, being in a community of a classroom or on a playground puts certain social expectations on these kids. And so the social component certainly does and can impact a child's ability to access the curriculum. If a child is so highly socially anxious and so focused on trying to figure out socially what's going on, then they're not going to be paying very much attention to the core curriculum. So we really have to recognize that this does impact these kids and is an important part of our educational planning. There are a couple of things drawn from actually the research that can give us really useful information. I don't have a lot of time to go over exactly what they are, but the Sally Ann task is a simple activity that you can do to be able to look at whether or not a child knows and can distinguish between what they know and what someone else might know or not know. And that really gives us an indication of where they're at in terms of theory of mind and the development of theory of mind. And we've provided for you some information, again, in your course materials about the typical development of theory of mind. And oftentimes, even the highest functioning students, those with Asperger's syndrome, we see significant delays. Sometimes, a third of their chronological age is where they're functioning in terms of theory of mind development. Another one is the Smarties task. Basically what you do is you take a container that the child's familiar with, but instead of having what they would expect in it, you take it out, put something else in there. So in this example, I might put paper clips or something in the Smarties box. And you ask the child, what do you think is in here? And they say, well, Smarties, and then you show them. And then you ask them to determine what they think a novel person would say is in the box. So they have to really be able to separate what they know, that there's paper clips in here, and what that other person might predict or think or know about what's in the box. How does theory of mind impact educational performance? By third grade, in terms of the curriculum, we're asking kids to make inferences, we're asking kids to predict, we're asking kids to think about other people's intentions, and if they can't even apply it to their own lives and their own relationships with other people, if they can't even think about what their mom or their dad or their sibling or their best friend might be thinking, it's going to really present some challenges in terms of some of those comprehension questions and some of those concepts that we ask them to do educationally. Can't talk about autism without talking about behavior. This is for the older and higher functioning kids. Oftentimes, one of the main reasons that they're referred for special education is because even though they might be progressing through the curriculum and they might have pretty good grades, their behavior starts to deteriorate. And it's usually between the ages of 8 and 12 that we end up getting the referrals to special education for students that are ultimately probably students with Asperger's syndrome. They come much later to our system, and it's typically because of behavior. So we have standardized measures that can give us really useful information, but we always want to augment that with our observations. And really, there's nothing more useful in terms of looking at behavior than looking at the context. And that includes looking at the antecedents, the conditions, the environments, the instructions that are being asked of these kids, and the outcomes and what it is that they're getting from doing those behaviors. This is going to yield the most useful information in terms of educational planning. What the antecedents tell you most of the time, whenever you're seeing a pattern of certain activities or certain task demands or certain subject areas where you're seeing a lot of behavior, it's probably going to tell you that you need to look at either how that information is being presented, something ecologically that's going on in the environment that's preventing the child from being able to demonstrate what they need to do. You may need to look at motivation. These kids are not as naturally motivated by socially based types of things, or the delayed gratification of a good grade. So we may need to look at making our motivation strategies more concrete and more immediate. Consequences are going to give you the biggest clue about the purpose of the behavior. And this is important for educational teams, because if you're dealing with a child who is demonstrating behavior that's interfering with their learning or the learning of others, or, in worst case scenario is severe or dangerous in nature, that is the #1 priority. These are the things that result in these kids having to be placed in more restrictive environments and not having access to their typically developing peers. So we've really got to look closely at the behaviors and identify what is it that they're attempting to either get and or escape or avoid via their behavior. And then teach those skills, those replacement behaviors, as a high priority on that child's IEP, as a goal objective through positive behavior support strategies and educational strategies. These are the common things that we see in terms of behavior. And I just want to point out, I'll go back to this slide real quickly. I put this slide together, and oftentimes I hear people say, well, he's just doing it for attention. And I never really accept that as a true rationale or reason or purpose for the behavior of learners, specifically those on the autism spectrum, because qualitatively it's different. Yes, they may be getting attention from other people via their behavior or as a result of their behavior, but most of the time what they're looking for is an interaction that's going to provide them with either clarification of what they're supposed to be doing, clarification of the expectations, or of why they're doing the work, an interaction that provides them with some form of regulating input or regulating feedback. So really looking at it in the context of the disability can be incredibly helpful. Chris is going to sum up our presentation with you today with a few final points and tips.
In 30 seconds. So data and information should inform the team about unique needs, direct us in terms of goals. Good goals is the marker of a quality IEP, is the marker of a good assessment. If you're able to design really good goals to meet the needs of the child, then you're headed in the right direction. So that's #1. What is their ability to learn in the group versus individual? What are the ecological supports that we've talked about and accommodations that are going to be required for that child to make progress? Are they going to need alternative communication systems like PECs? Are they going to need visual supports? Are they going to need more frequent reinforcers to motivate them in the curriculum? And the assessment should inform the team about those specialized interventions and instructions. What is that child really going to need to make progress? Is it going to be ABA? Is it going to be structured visual supports? What are those specifics that need to take place in that child's education? So takeaway messages. These are kids with varied and complex needs. It does require additional time. It requires really a specialized team whose passion and work is to figure out kids with autism, to provide a thorough assessment and direct that team towards good educational intervention. Parent involvement is absolutely critical in every step and in every way. And we can't rely solely on standardized tests. We need to really become fluent and comfortable in those structured and unstructured informal observations. So thank you so much today for your time, and enjoy the rest of the day.
The UC Davis Mind Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.